Our third presenter of the day is Katelyn Payne. Katelyn earned her bachelor's in biology and her associate's in nursing from Purdue University in 2007. She worked as a pediatric nurse in Chicago for 2 years before moving to Indianapolis to attend IUPUI's genetic counseling program. She graduated with her MS in genetic counseling in 2011 and spent the first 7 years of her career working in medical genetics and child neurology at Riley Hospital for Children. Since 2018, Katelyn has worked in neurology at Indiana University Health. She and her husband live in Indianapolis and have 3 children. Thank you for being with us today, Katelyn.
Yeah, thanks so much for having me.
I will stop my share so that you can share your screen and your presentation.
Okay, are you guys seeing?
Yes, I can see it.
You can see it, okay. All right. Are you in presenter mode?
I cannot see your presenter mode, just you.
But you can see the slides. Okay.
Yes, we can see the slides.
Sorry. I've got 2 screens here, so just want to make sure I'm doing this right. So thank you so much for introducing me. Yes, so my name is Katelyn. I'm a genetic counselor with Indiana University Health, and I work in adult neurology. And part of my role in my job is to see patients in our muscular dystrophy clinic. So I do see lots of different types of limb-girdle muscular dystrophy. So today what I wanted to talk about was just sort of a review of limb-girdle muscular dystrophy, including the subtypes and how we differentiate them genetically. And then I wanted to focus on genetic testing for this group of disorders. So what do we use to make the diagnosis? What are the possible results that someone could get when they do genetic testing? What's the benefit of having a genetic confirmation? And if we do have a genetic confirmation, then what testing can we offer to family members? Ethical considerations, that's certainly something to think about with genetic testing. And then also barriers to testing, which can include insurance coverage. So I was going to touch a little bit on insurance considerations, and then talk about reproductive options once a genetic diagnosis is confirmed. There are also lots of sponsored genetic testing programs that have become available in the last several years. So I did want to touch a little bit on that because I think that can decrease some of the barriers to testing. And then I'll briefly touch on some resources for genetic testing in muscular dystrophy as well. So limb-girdle muscular dystrophy, the overall prevalence, if you include all the different subtypes, is about 1 in 20,000. And so these particular types of muscular dystrophy are characterized by skeletal muscle weakness, primarily in the proximal muscles. So that includes the shoulders, the upper arms, hips, and thighs. Signs and symptoms can appear at any age, depending on the subtype, and tend to be slowly progressive in nature. So typical initial symptoms can include changes in gait and difficulty running. That's what most people will report first. Shoulder weakness can actually make the shoulder blades appear very prominent, or the scapula can appear very prominent. And then there can be changes in the spine. So we can see lordosis, which is an exaggerated curvature at the base of the spine, and then scoliosis, which is the S-shaped curvature of the spine, and joint contractures. So people have a hard time fully extending, usually at the elbows and the knees, but they can get contractures of any joint, really. Some of the subtypes of limb-girdle muscular dystrophy will include cardiac involvement, and some will include respiratory involvement as well. And then one thing that differentiates the limb-girdle muscular dystrophies from other types of muscular dystrophy is that intellectual ability is usually normal in this group. So as far as classification, there's 2 different items that we use to classify these disorders genetically. So the first is mode of inheritance, whether that's dominant, recessive, or X-linked. And then second is the genetic etiology. So to date, there have been at least 27 different subtypes of limb-girdle muscular dystrophy that have been described, all with different genetic causes. And most of these genes function in muscle maintenance and repair. So a change in that gene somehow leads to skeletal muscle weakness. Limb-girdle muscular dystrophy type 1 are those that are autosomal dominant in inheritance, and type 2 are those that are autosomal recessive. And then most of the type 1 or type 2s are followed by an alphabetical letter, and that letter just represents in what order was the gene discovered. So limb-girdle muscular dystrophy type 1A is going to be a dominant form that the gene was, the very first gene that was described or discovered.
Hey, Katelyn, I still see your title slide. Have you moved it?
I have.
I just want to make sure. No, not yet. Do you want to unshare and then try sharing one more time?
Yeah, I'm sorry about that. It said
That's
my
okay.
sharing was paused.
Right now we're at the slide, limb-girdle muscular dystrophy. Overall prevalence is 1 in 20,000.
Okay. And then classification?
Yep.
Okay.
Yep, now it's moving.
All right. I apologize. Thanks, Michelle.
Nope, thanks.
Okay, so this is what I was talking about with mode of inheritance. So type 1 being dominant, 2 being recessive. So one utility of genetic testing is that many of the subtypes can look very similar to one another. So it's not always possible to differentiate clinically. If somebody comes into clinic and we think they have a limb-girdle muscular dystrophy, and if there's no family history, we can't just pull out of our hat, type 2B or something. So genetic testing can really help us differentiate the type of muscular dystrophy because there is so much overlap, not only between the subtypes, but also within each type as well. Okay, so I just thought I would run through some of the most common forms of limb-girdle muscular dystrophy. I'm sure there's people on this call today that fall into these different categories. So the most common type is limb-girdle muscular dystrophy type 2A, which is a calpainopathy. It's caused by a change in the CAPN3 gene. So it is a recessive form, and that's what the number 2 delineates. And the frequency is anywhere from 15 to 40% of cases. And I realize that's quite a broad range there. So it really depends on the ethnicity. This is a muscular dystrophy that we see in people of all different ethnic backgrounds, but the frequency can differentiate depending on, North American or Northern European Caucasian, African, Asian. There's a little bit of difference there. The second most common type is the dysferlinopathy, which is caused by a change in the DYSF gene. So this represents limb-girdle muscular dystrophy type 2B, so it is a recessive form, and it is about 5 to 35% of cases. The sarcoglycanopathies are the third most common type of limb-girdle muscular dystrophy. So this represents types 2, D, E, C, and F. There's 4 different genes that have been associated with the sarcoglycanopathies, and they represent about 10 to 20% of limb-girdle muscular dystrophy. Fourth is the dystroglycanopathies. Again, this is 4 subtypes of limb-girdle muscular dystrophy and represents about 10 to 15% of cases. Fifth is limb-girdle muscular dystrophy type 2L, and this is caused by a change in the ANO5 gene. And we see it in about 15 to 40% of Northern European Caucasian individuals. However, we think the frequency is quite a bit lower in other ethnic groups. And then lastly is limb-girdle muscular dystrophy type 1B, which is caused by a change in the lamina gene. And this represents about 5 to 10% of cases. And one thing that I wanted to mention on this slide is many of these genes, so for example, the dystroglycanopathies, not only are changes in these genes associated with the limb-girdle phenotype, but they can also be associated with other muscle diseases. So muscle eye brain disease is another disorder that's caused by changes in dystroglycan genes, which is, as it says, muscle, eye, and brain involvement. It's a congenital muscular dystrophy. So when we're doing the genetic testing, even if we find a specific gene, it doesn't always tell us the clinical diagnosis. So that's where, we look at what region of the gene was the change identified, obviously phenotypically, what does the patient look like? And then that helps us in making the diagnosis. So I just wanted to kind of point that out, that there can be overlap in specific disorders that occur within the same gene. So other forms of limb-girdle muscular dystrophy, changes in the titin gene can cause limb-girdle muscular dystrophy type 2J. This is a gene that's a perfect example of changes in titin can cause all sorts of different disorders. I think probably most well known are the cardiac disorders that are associated with titin changes, but they can also present as a limb-girdle muscular dystrophy. And then there's certainly other forms that we haven't yet identified the gene, or have only been identified maybe in one family or a handful of families from a certain ethnic group. And so we are learning quickly, but all that to say, we've not certainly identified every gene associated with this group of disorders, and I still think we have a lot of work to do in that area. So other related disorders, and I just wanted to make mention of these because I think depending on where you look or where you read, sometimes these other disorders will get lumped into the limb-girdle muscular dystrophies, although we do think of them as distinct or different from this group. One is the dystrophinopathy. So this is caused by a change in the DMD gene, which is associated with Duchenne and Becker muscular dystrophy, which is one of the most common types of muscular dystrophy. Bethlem myopathy, which can have some overlap with limb-girdle, although it's caused by a change in a collagen gene. The myofibrillar myopathies, which actually some of the genes that cause limb-girdle can also cause a myofibrillar type picture where people have distal muscle weakness first. The metabolic myopathies and the inclusion body myopathy, those can often be on the differential when we see patients for a limb-girdle workup. Pompe disease, and then facioscapulohumeral muscular dystrophy, or FSHD. And those are two that I've often seen associated with the limb-girdle umbrella as well. So as far as making the diagnosis, so when we see a patient in clinic and it's their first appointment in our muscular dystrophy clinic, the things that we're trying to understand are the defining features. So when did symptoms start? What was the first symptom that was observed? How quickly have symptoms progressed? What's the category of this disorder? Do we think it's a limb-girdle? Do we think it's more likely to be an inclusion body myopathy? Is it more of a distal muscle weakness picture? Can we lump it into a category that would help us know specifically what genes to look at? And then another big tool for us is family history. So I spend a lot of time asking about family history. Who else is affected? Is there a clear pattern of inheritance? Has anybody else in the family had genetic testing? Do we know if there's an underlying gene change? Those types of things. We can consider a muscle biopsy in making the diagnosis. We can do that with immunostaining, looking at certain proteins, either the absence or the presence of certain proteins that would help us make the diagnosis, and then genetic testing. So we usually jump to genetic testing first because it is the preferred diagnostic test at this point. There are broad panels available looking anywhere from a handful of genes to hundreds of genes, all associated with muscular disease. One risk when you look at really broad panels is that you can get variants of uncertain significance, which are just changes in genes that we don't quite know what they mean. So they're in that gray zone where we see the changes there, but then how do we interpret that in the light of the patient's symptoms? And so I think variants are difficult because they may or may not be related, but sometimes, we'll require further steps to kind of figure out exactly what they do mean for the patient. Genetic testing is more precise than, say, a muscle biopsy or just measuring CK levels, things along those lines. So certainly when we do a muscle biopsy, we can see if there's dysfunction, if there's abnormalities in the muscle cells themselves, but we don't know the why behind it. So even though the muscle biopsy can tell us, okay, things aren't looking right or things aren't working quite right, we still don't know why they're not working correctly. And so the genetic testing really gives us the why behind that. And then as I mentioned, even within the same gene, there can be variability of symptoms. So it is helpful to know the specific change so that we can use that information to compare to the literature and see, what does this fit best. So when we do genetic testing, there are 3 result possibilities. The first is a positive result. So we get a change in a gene that is known to be disease causing. It makes sense in light of the patient's symptoms and in light of the patient's family history, and it's sort of a slam dunk, right? We have a name, we can do all the things that we need to do with genetic testing, including predicting prognosis, and it's very straightforward. A negative result means a couple of things. Either we're not looking at the right group of disorders, and we need to either consider doing a broader panel or looking for a different type of underlying muscle disease, or perhaps it's not genetic, and it might be an acquired or an autoimmune or an environmental issue. And so then the question is, okay, what are other appropriate tests that we could offer to this patient to determine what is their diagnosis? And so a lot of times I'll tell patients, genetic testing is helpful in that it either rules something in or it rules a lot of stuff out. And so, if we look at hundreds of genes and we don't find anything there, that doesn't mean it's not genetic, but we've at least taken those things off the table for the patient. And then variants of uncertain significance. So I mentioned this on the previous slide. This is the gray zone area that I think is the most difficult to determine what that means for the patient. So the test report will often provide some additional information about the variant. Where is the change located? What is the effect on the protein? Is this a change that is common in the general population? Does it seem to be a rare change? Has it been reported in the literature? And then we use these online prediction tools called in silico analysis, where we can plug the gene change in and say, is this change likely to disrupt the protein product? So that was helpful in knowing, is this likely to be tolerated? Is it likely to be deleterious? Or, occasionally you'll get conflicting results there. And then, how do we learn more about a variant of uncertain significance? So some labs will offer free testing for family members. It's especially helpful when there's other family members who are affected, who we can submit their samples and look and see, is the variant of uncertain significance segregating with disease in the family? Or on the flip side of that, can we test a parent or a sibling who's healthy and see if they carry the variant, and then determine from there, what do we think that means in light of the patient's symptoms? We can also order RNA functional studies. So I don't know if you remember from biology, DNA makes RNA, makes protein. So if the DNA has a change in it and is abnormal, then we can look and say, okay, is this making a normal RNA product? Do we think it's disrupting protein production? And can that give us more information about the change? And then the third option is just letting enough time go by that variants, eventually get reclassified. Not always, but certainly the more people that we test, the more people that we have in our database, that can help us know if a change is disease causing or if it seems to be a rare benign change in the general population. And so labs will sometimes on their own issue new reports if a variant's been reclassified. But also as clinicians, we can ask the lab for a reanalysis, again, after enough time has gone by, just to say, hey, has there been any changes in the classification of this variant? So we think, or we're estimating that we make a genetic diagnosis in about 60% of patients with limb-girdle muscular dystrophy. So that leaves 40% that either the cause is unknown, or again, they're living maybe in that variant world where they have a change that we don't quite know what it means. So there's lots and lots of benefits to confirming the genetic diagnosis. And I have a couple of slides just highlighting what I think are probably the most important reasons to confirm a genetic diagnosis. The first is that it helps us predict long-term prognosis. So, I try to tell patients, we obviously don't have any crystal balls, but if we can give you a specific name, then we can say, okay, how do other people with limb-girdle muscular dystrophy type 2F say, how do they do over time? We know most of these disorders are progressive, but how quickly do they progress? And Depending on the age of onset and how quickly things progress, that can also help us know how to counsel patients on making modifications to their home, to their lifestyle. So, is this a disorder that we expect to progress to the point of needing a wheelchair? And if so, at about what age does that happen? And, do you need to make adjustments to your home so that you can still live independently? And that's really our goal, is how can we help this person live independently for as long as possible? And so having a specific name or a specific type of muscular dystrophy really allows us to shed a little bit of light on some of those questions. It also often clarifies the inheritance pattern, and from there we can determine what's the risk to other family members. So do other family members, and usually the question is for parents, for siblings, and for offspring, do they need to consider testing? And I think that comes down to, is this a type of muscular dystrophy where there's cardiac involvement, respiratory involvement, that if we know about the disorder in advance, then we can screen for those other complications and hopefully avoid any, long-term or sudden cardiac events that if we knew in advance, we could be proactive in screening for those complications. Other benefits, so management and treatment. There are certainly some just general management and treatment recommendations for patients with limb-girdle muscular dystrophy. But again, if we know the specific subtype, then we can tailor that to what specifically the patient's experiencing. So we really focus on prolonging survival, improving quality of life. That often involves regular therapies, stretching, physiatry or physical medicine intervention to prevent joint contractures, promote mobility, any of the other complications that can pop up. Certainly surgical intervention is sometimes warranted depending on the complication. And then looking at assistive devices, so orthotics, wheelchairs, anything else that can again improve quality of life and improve independence. And then surveillance of other organ systems. So the two big ones with the limb-girdle muscular dystrophies are cardiac and pulmonary. Again, looking for cardiac arrhythmias, cardiomyopathy, the need for respiratory support, and things along those lines. So if we know the specific diagnosis, then we can help tailor our approach based on what we know about additional or secondary complications that can happen. So the other benefit of confirming a genetic diagnosis is that we can then avoid unnecessary treatments or procedures. So for example, if a patient is misdiagnosed with an inflammatory myopathy, or perhaps like a Duchenne or Becker, where steroid treatment would be recommended, we can avoid these things if we know genetically that there's no benefit to these medications, which of course, in and of themselves, the medications have side effects and risks there. Some of the subtypes don't have any cardiac or pulmonary involvement, which, if we don't know the diagnosis, then we generally recommend that patients have cardiac and pulmonary screening annually, because we certainly don't want to miss something. But if we can confirm the subtype, then we can sometimes avoid those unnecessary appointments that is just one more thing to have to do, on the calendar each year. And then if we can make a genetic diagnosis, we can often avoid a muscle biopsy, which is, an invasive procedure that has its own risk associated. And so if we can avoid that altogether, I think that's a huge benefit as well. And I've certainly seen in my time in neurology, even in just the last 8 years, how much we've gotten away from doing muscle biopsies. So that used to be sort of the gold standard. That's what we jumped to. And as we've improved, not only in just our accuracy of genetic testing, but also discovering more genes, the cost of testing has come down quite a bit. We are usually using genetic testing as the first line and avoiding muscle biopsy whenever we can. Again, because the muscle biopsy is not telling us the why behind the dysfunction. And then the last thing I was going to mention regarding the benefit of confirming a genetic diagnosis is just the opportunity to participate in a clinical trial. So if we know the subtype, we can look specifically, are there any natural history studies or interventional trials for this specific type of limb-girdle muscular dystrophy? And is there a patient registry available? So even just being in a patient registry can be beneficial to the patients because it does allow for quick contact if and when a trial becomes available. So I usually encourage patients, if there's a registry available, be a part of it if you can, because if there's anything on the forefront, if there's anything on the horizon as far as treatment or management opportunities, then you're going to be able to have that knowledge as soon as it becomes available. And that's another reason that we like to follow patients in our clinic long term. Even if we're not doing much for them as far as from a management or treatment standpoint, it still allows us to have communication with them and them to have communication with us, so that if we are approached for a clinical trial or there is something that seems to be coming down the pipeline as far as treatment, we can have a way to communicate that to them as well. So testing for unaffected family members. So this is something that I wanted to spend a little bit of time on today because I do get asked this quite a bit. So our preference when we approach genetic testing is to test the affected or the symptomatic family member first, because their results are going to be most informative. We know they have limb-girdle muscular dystrophy. If we find an underlying gene change, we can say, okay, this appears to be causative. And then once the genetic diagnosis is confirmed, we can offer testing to at-risk asymptomatic family members who may benefit from that information. And so I think the question to ask the person who is unaffected but considering testing is, what benefit do you think that testing is going to have for you? And certainly it's a very personal decision, and one that I think genetic counselors have the skill set to, talk through with that person and say, is this an appropriate decision for you? So, one question to ask is, when does the muscle disease in your family start? How old is this person now, obviously, and then depending on the subtype running in their family, are there screening recommendations such as cardiac or pulmonary screening that would make that answer yes, like you should test, because if we know in advance, we can be proactive in looking for these other complications. And if the answer to that is no, there's no cardiac, there's no pulmonary issues associated, and right now, there's no treatment that we know of that you can do in advance to either delay the onset of the disease or slow the progression, then it really becomes just a personal decision. Do you want to know this information in advance? And people feel very differently. Some people say, yes, I want to know, I want to prepare for anything that could happen. And other people say, if it's going to happen, it's going to happen. And I really don't want to know in advance if I'm going to need a wheelchair in my 50s or 60s or 70s. So again, we're just here to give the information, and then patients ultimately make the decision that's best for them. I think some of the main reasons why people pursue predictive testing is for making decisions about reproduction. That's a big one. Finances and career planning is another big one. So I recently saw two brothers who their grandfather had a muscular dystrophy that they knew was X-linked. So they knew their mother was a carrier, and they knew they were both at 50-50 risk to develop this disease. And they were actually both in medical school at Indiana University, and they were at the point in their training where they were considering which residencies to pick. And so when I saw them, their thought process was, okay, our grandfather, he needed a wheelchair in his late 50s, early 60s. So if we're going to be at that point, then we should think about a career in medicine that maybe, is not surgery or something that's not as physically demanding, where we can still practice medicine, but see patients in an outpatient setting, don't have to be on our feet all day, that kind of thing. And so I thought that was just a really good example of how people use genetic testing to help with just career and life planning. And so the reason we recommend genetic testing is so that people have the opportunity to think through both a positive and a negative result, and then what they're going to do with that information. So how do they feel like that information is going to be beneficial to them moving forward? And again, that's a different answer for every person. So, I'll usually ask something like, okay, so why now? Why have you come to the point in your life that now is the time that you feel like you want this information? And do you feel like the benefit of knowing is going to outweigh the risk of knowing? Because there's certainly risks associated with genetic testing. There can be psychological risks. So, I think there's depression and anxiety sometimes surrounding the unknown, but then once you know, you can't unknow, and that's hard. And so I just try to talk through with patients, your genetic status was determined at the time of conception. And genetic testing is not going to change your gene status, but it does change your knowledge about it. And how do you feel like you'll react to that knowledge? Will it change your self-perception? Will it change your relationships with a significant other, with offspring, with siblings, those types of things. And then a lot of people have fear about genetic discrimination. And I have another slide later on to talk about that, but certainly I think there historically has been some fear in genetic testing as far as, am I going to be discriminated in the workplace, in either health insurance, life insurance, and those types of things. And then timing. So what is the timing of wanting the genetic testing done? And certainly we recommend a supportive environment without other stressors, but I also realize that's probably a laughable statement since really there's not life without stress, right? And so just looking at times that I feel like are not great to test is when, say, a parent who has a limb-girdle is, at the end of their life, or they've just lost a parent to a specific type of muscular dystrophy. I think that's a difficult time to test, but I will say that I think also brings out those feelings of wanting to know, am I going to develop this as well? And then also when people learn about a genetic muscular dystrophy in their family, and especially if it's new information and they didn't realize there was a genetic cause to, a parent or a sibling's symptoms, I think the knee-jerk reaction is, oh, I want to test now. I want this information now. But, they've only learned of it, say, the last few weeks or last few months. And so sometimes I think it is helpful to just sit with that information and let a little bit of time go by and say, okay, do I really want this? Am I really ready? And just, have that time to be reflective about the information. And then there's a group of people that are just information seekers. So they know they're at risk, and the uncertainty is more overwhelming than just knowing. And certainly I can appreciate that. Every time they have a backache or they trip up the stairs, they start to think, oh, am I developing this? Is this happening? And so that uncertainty is more anxiety provoking than just knowing their gene status one way or the other. And certainly I can appreciate that as well. But I think ultimately, the summary is, if you're an at-risk individual, there's really no easy decision in thinking about testing. And again, it comes down to, it's a really personal decision, and what do you feel like is the best choice for you? So a few ethical considerations I just wanted to touch on. One is the testing of minors. So if there is an adult onset muscular dystrophy running in the family and there's no screening recommendations before the age of 18, then we typically try to not test minors, again, unless there's a medically compelling reason. And a few reasons for this. One is that we really want the person themselves to be an adult and be able to autonomously decide if and when they want that information. And then two, because of the risk for discrimination. So we've certainly seen, just retrospectively, and not just limb-girdle muscular dystrophies, but other neurodegenerative disorders, that when a minor is tested and that label is put on them, then there can be changes in the way that parents parent their children, knowing gene status of one or the other, or how hard they push them, or those kinds of things. So again, we try to avoid it unless there's a medically compelling reason to test a minor. And then confidentiality. So this is a big one with genetic testing. There is a federal law in place called GINA, which is the Genetic Information Non-Discrimination Act, and this was signed into law in 2008. And this says that your health insurance and your employer cannot drop you based on gene status. And that includes your family history information, any genetic testing results, participating in genetic counseling or genetic services, and then also participation in research is covered under GINA. So what's not covered is life insurance and long-term care disability insurance. So this is another reason that we like people to go through genetic counseling before they decide to pursue predictive testing, because we want to make sure that they've had the opportunity to get life insurance and long-term care disability insurance plans in place before they test. Because if they are gene positive, we don't want them to have to disclose something they don't feel comfortable with and then potentially not be able to get life insurance or long-term care. And the difference is that, you know, for somebody who's affected, so for somebody who already has the diagnosis,
It looks like Katelyn might have frozen. Katelyn, can you hear me?
so barriers to genetic testing.
Hey, Katelyn, you were frozen a little bit for like the last maybe minute. So if you want to kind of move back just a little bit.
Did you hear me talking about Gina?
No. Yes, yes.
Okay. So yeah, so the bottom line with Gina is just health insurance and employer can't discriminate. What's not included in Gina is life insurance and long-term care disability. So getting those plans in place before you test is really helpful for the unaffected individual, so that you don't have to disclose something that you don't want to. Okay, I'm sorry about that. Okay, so barriers to genetic testing. So I think historically the biggest barrier has been cost and insurance coverage. So I will say my very least favorite part of my job is dealing with insurance companies, health insurance companies, because most of the time they will say that a genetic diagnosis is not going to change medical management, so they don't want to cover the cost of testing. And I understand their argument that whether it's, you know, limb-girdle 2A or 2B, you're going to treat it the same. And whether that's true or not, certainly there are minor differences in how we treat the subtypes. Ultimately, genetic testing often gets denied by health insurance companies. So this can be a huge barrier. Now there are a lot of genetic testing companies that will offer self-pay pricing to patients. And we've seen that self-pay price go down quite a bit over the last few years. So now the two labs that I use most frequently, their self-pay price is about $250, which is way better than it used to be. So we are seeing the cost decrease. And then with insurance concerns, as I mentioned on the previous slide, there can also be the risk to be denied for life insurance or long-term care disability. And so that is certainly a barrier to testing as well. And then I think there's just, you know, the unwanted information. Not everybody wants to know if their disease is genetic or not. And I think, you know, not only are you dealing with a degenerative disease for yourself that's progressive, you're trying to figure out how to make accommodations to improve quality of life, but then knowing that this is something you could have passed on to your children, I think that there is certainly some fear and some guilt that can be associated with that. And so I just really try to tell patients, you know, we don't get to pick what we pass on to our kids. We would all pass on our most wonderful qualities if we had a choice. And so trying to just take away that feeling of guilt, that I can understand that as a parent, but I also think, you know, just want to normalize it and allow for as much knowledge as possible. And then logistical barriers. So I will say that one of the silver linings of COVID has been that we can almost do the entire genetic counseling and testing appointments remotely. So for patients that aren't able to come into clinic, I can usually mail saliva kits for testing, and they're able to do cheek swabs at home. And again, that can alleviate some of the logistical barriers that surround testing. So insurance, I feel like I've talked about this kind of a lot at this point. So with patients with commercial insurance, we can usually perform a benefits investigation either through the testing laboratory or by calling the insurance company to just verify coverage ahead of time. So is this covered? And then if not, can we offer self-pay to the patient at something that's a reasonable cost? Medicare, so we do have a fairly large Medicare population in our muscular dystrophy clinic. And Medicare is difficult because they won't tell you in advance whether or not genetic testing is covered. So we're able to appeal the decision after testing's been done and if it's denied. But also, one advancement is that several commercial labs that we use will actually perform testing for Medicare patients at no cost. So this has become less of a barrier over the last few years. And the same with Medicaid. So most genetic testing labs are in network with state Medicaid plans so that Medicaid patients with Medicaid coverage are not seeing any out-of-pocket cost associated with genetic testing. I do try to tell whenever I get the chance to tell the ordering physician that if they're able to document how genetic testing will impact management, then this will help with insurance coverage. I think insurance companies tend to be a few years behind the current technology. And so if we can sort of prove to them, hey, if this person has this type of limb-girdle muscular dystrophy, then we can avoid the cardiac screening that they've been doing once a year. We can avoid that cardiac MRI. We can avoid these pulmonology appointments. And so if they can see genetic testing as a cost saving mechanism, then I think they will be more likely to cover it going forward. And then sponsored programs. So again, this has sort of become available in the last few years where we're able to offer testing at no cost to affected individuals through these sponsored programs. And I know the MDA is a part of that. So briefly touching on reproductive options, this is something that Michelle had mentioned was of interest. So if the genetic etiology is known for an individual or a family, then these reproductive options become available. So if we know the gene in question, then individuals who are either at risk or affected themselves can go through in vitro fertilization, where they harvest egg cells, fertilize embryos, and then they analyze the embryos for the specific gene change that's running in the family. And they transfer embryos that are unaffected for implantation. So again, it's a way for people to have biological children, but to know that they're not passing on the specific type of muscular dystrophy in their family. Another reproductive option is prenatal diagnosis. So, conceiving the old-fashioned way and then doing testing either via chorionic villus sampling at 10 to 14 weeks gestation or an amniocentesis at 15 to 22 weeks. I think the question is here, depending on what the results are, does the couple continue the pregnancy? Because of course, that in and of itself has its own ethical issues, but also now you've just tested a minor for what may or may not be an adult onset disorder. So I really try to just frame this as, here's the options that are available to people. We want you to know what the options are, but again, ultimately, everybody makes the decision that's best for them, based on their own beliefs about these types of technologies. So the sponsored testing program that I use most frequently is called Detect Muscular Dystrophy, and this is through Invitae Genetics. It's sponsored by Cure, VCP, and the Muscular Dystrophy Association. Cure VCP. So VCP is a gene that changes in this gene can cause muscular dystrophy, but can also cause ALS and dementia. So there's quite a bit of phenotypic overlap there, and it is included on the neuromuscular disorders panel. So this testing can include just the DMD gene, which is associated with the dystrophinopathies. They do offer a specific limb-girdle muscular dystrophy panel, which includes 38 genes, a more comprehensive muscular dystrophy panel, which includes 53 genes, and then the neuromuscular disorders panel, which is 211 genes. And again, with this broad of testing, you're always going to run the risk of variants of uncertain significance. I think of genetic testing a little bit like Pandora's box. Once we open it, we can't close it. And so there's changes there that may or may not be related to the patient's clinical presentation. So it may be helpful information, it may be too much information for some people, but again, trying to tailor the panel to specifically what we're seeing clinically. So program eligibility, and it's really not hard to qualify for this program. So most patients that we see in clinic, we are able to get the free testing done. So they only have to have one of the following. So progressive muscle weakness, an elevated CK level, either a presumptive positive Duchenne testing from newborn screening, cardiac or respiratory involvement, calf hypertrophy or pseudo hypertrophy where the calf muscle is enlarged, a muscle biopsy that is abnormal, or a family history of muscular dystrophy. So again, most patients are going to check one of these boxes, and if they check one or more boxes, then we're able to offer the free testing program, which has just been so nice for our patient population that we don't have to deal with insurance. They don't have any out-of-pocket responsibility to do the testing, and we have results back for them in about 3 to 4 weeks. So it really helps with the diagnosis. Again, as I mentioned, either ruling something in or ruling something out, and then helping guide our next steps as far as if it is negative, okay, what do we need to do next? Or if it is positive, then okay, what do we need to do next? What are our screening recommendations? And then how can the rest of the family benefit from this information? So a couple resources I just wanted to highlight today. So for anyone who is looking for a clinical trial for their specific type of limb-girdle muscular dystrophy, the best website is clinicaltrials.gov. So you can either type in your subtype or the gene name, and anybody who is looking at that type, it should pull up the trial and tell you whether or not they're recruiting, whether they're active and not recruiting, or if the trial's been completed, then sometimes you can get some information there too. And if you are looking for a genetic counselor in your area, the website that I would recommend using is the nsgc.org website. And if you go there, you can see at the top, they have a button that says find a genetic counselor. And so you can plug in your location if you're looking specifically for somebody in neurology or neurogenetics. And then find someone near you who can, be of help to you as far as accessing genetic testing or accessing a provider who can order this for you. And lastly, here is my contact information. So I just wanted to say, if you have specific questions that I'm not able to answer today, please feel free to reach out to me. I would be happy to be a resource to you and your family going forward.
Thank you, Katelyn. I'll now open the symposium up to any questions that anyone may have. I know some have already come in. One of the questions is, one of your slides said a genetic diagnosis can be made in at least 60% of limb-girdle patients. Earlier, Dr. Johnson said around 25% are genetically diagnosed, 50% are VOUS, and 25% are completely unknown. So I think they're trying to figure out the difference between his 25 and your 60.
I don't know. I didn't see his presentation, so I'd have to see where he got his information. I got mine from a paper that was published in 2019 that we're making a diagnosis in about 60%.
Yeah, we will ask Dr. Johnson to just find out where he got his numbers from as well. Would it be possible, what would the cost for a full genome sequencing if a person paid for it themselves? Would this be helpful? I've had genetic panel tests done over the years and have never gotten a diagnosis.
So the lab that I use, their self-pay price for whole genome analysis is between $400 and $600. So again, I think that depends on the person and if that's something that's financially feasible. But yes, it could be beneficial in that, if the change that this person has is outside of the typical neuromuscular disorders panel, and maybe it's something else that's looking, like say a mitochondrial disease that looks very similar to a limb-girdle muscular dystrophy or something, then yeah, there may be some diagnostic yield there.
Thank you. And during your presentation, you mentioned some sponsored genetic testing programs, and I will be mentioning a genetic testing options for limb-girdle material resource that MDA has just recently created, which includes the links to the one that you mentioned and also a couple more. So those will be available to all of our attendees and registrants today.
Okay. Great.
See, we'll wait for any other questions to come in. If you see the Q&A bubble on the bottom of your screen, go ahead and click that, or you can click the chat and enter your question there. Earlier, we had an attendee ask how, during Dr. Johnson's presentation on research and clinical trials, how can we get a specific diagnosis for a limb-girdle type? So obviously the answer was genetic testing. And using that genetic test is how people will be able to know if they are eligible for the current clinical trials that Dr. Johnson is working on. So we're all working together in some way.
We are. Sometimes it's not fast enough, but a lot of people are working hard on this. So
that's right. A question has come in. Can you tell me what FKRP means?
It's a specific gene name, FKRP. Is that what? I don't know the name of the protein off the top of my head. But yeah, it's one of the dystroglycanopathy genes.
It looks like
gluten-related protein.
Yes. Looks like we have a doctor on the line today, so that's great. Thank you. Oh, a few more questions have come in. Would my sister and I have the same type? She has been tested, I have not.
We would assume so, yes. We would assume that if there's two family members that closely related, that they have the same type of muscular dystrophy.
Another question that has come in is they were diagnosed with limb-girdle 2A via muscle biopsy over 15 years ago. Should they retest?
I would say yes. I would be interested to confirm that what was seen on muscle biopsy is true genetically. So my guess is they saw a change in the cowpea protein, and so it'll be interesting to see if that is also identified in the DNA. You know, if that person has two disease-causing changes in the gene as well.
How long would you recommend somebody to get? Maybe they got, you know, a genetic testing or a muscle biopsy done 10 years ago, 15 years ago. At what length do you recommend them to retest?
Oh gosh, okay. Length to retest is difficult. I mean, I would say anywhere from 2 to 5 years is enough time that you could consider retesting. That we've had, you know, basically enough number of patients and new genes have come out that it would be worth your while to reinvestigate. I would say anybody who's had testing more than 10 to 15 years ago would definitely benefit from retesting, because, you know, the limb-girdle panels 10 to 15 years ago had 5 genes on them, and now we're up to, you know, 40 genes.
Wow.
So we have come a long way, and so I think it would be worth it for anybody who doesn't have a specific diagnosis to have that, you know, specific name associated with their diagnosis.
Thank you. Back to the FKRP question. Does this indicate 2I?
Yes.
Okay. We'll wait a little longer for any questions to come in. I think it's exciting to hear that, you know, there used to be 5 and now there's 40. And I think the more research is done, that number is just going to increase, which is great.
Yeah, no, I think like I said, we're learning a lot, we're learning quickly. I realize sometimes it's not fast enough for our patients, but, you know, we've made great strides even in the last decade. So it's exciting to think about where we'll be in another 10 years.
That is awesome. Well, it looks like that is all of our questions from our attendees today. We actually have a story from our MDA tech who is in the background, but she has a story that she was originally diagnosed at 9 years old with limb-girdle 2D via muscle biopsy. And 2 years ago, she did genetic testing and found out that she actually had limb-girdle 2C. So that is one great example of how a muscle biopsy and genetic testing gave them a different diagnosis.
Yes, yeah, that is interesting.
Well, thank you so much, Katelyn, for being with us today and presenting on genetic testing. Really appreciate all you do for the neuromuscular disease community. One more question has come in. Could results from a genetic test 10 years ago give different results today?
Yes, yes. So that would be the short answer. I would say, what was on the test 10 years ago? Like, was the same gene included? And then also, our technology's improved. So I've had patients who, if they did testing 10 or 15 years ago, maybe one mutation was found in a gene. But when we repeated testing, we found 2 mutations in the same gene, and we probably just weren't able to capture the second change because technology wasn't good enough.
Right.
So the results could change. And it's probably a reflection of improved technology and then also improving the number of genes that we're looking at. I hope that answers the question.
It's always an it depends.
Yeah, and it depends, right?
Well, Katelyn, thank you so much for taking the time out on your Saturday. We really appreciate you being here with us.